Oh, okay. Were they? Right. We'll have to keep an eye on it. Not so you don't drive a day. I mean, I don't. My doctor's here, Amber. I'm gonna just leave it on speaker. Okay. Yeah. Yeah. Go for it. I'm done.
Okay, I'm going to show you some pictures.
Okay. Hold on. I'm gonna just set you down.
Okay. So the CT was very helpful. It didn't show a fracture, but it showed some other things which are actually very critical to the discussion in terms of, okay, if you do this option, this is the risk versus benefit versus something else.
Okay.
So I want to show you, this is the MRI which we already had.
Right.
This is MRI cross sections. You can see that big disc on the right side, on the left side.
Yeah.
You can see the left side, this side is wide open. The right side.
Okay.
Okay, that's wide open. The left side is this. You can see the difference. You can see that nerves here, but you can't even make it out on this side. See, okay?
I see.
All right. So we already knew that based on the MRI.
I'm gonna shut this off.
Okay. But when you do the CT, a couple of things. So look, by the way, your spine overall is in pretty good shape. It's just a 4-5.
Yeah.
It's interesting because a lot of the times all levels have some degree of wear and tear.
Yeah.
One is bad. Your 4-5 is really bad, but the rest of them are actually look pretty healthy, which is good.
My age. Yeah.
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 You can see this is a normal disc.
Yeah. The space between that one.
Right? So number one is totally collapsed, which is by itself doesn't mean much. A lot of people have bone on bone. It's asymptomatic. But what I want you to see is this in the back. The disc is totally covered with bone, which is not common or normal. And as an implication of surgery standpoint, look at this here. In the right corner, you see this piece of bone sticking out?
Mm-hmm.
That was some point was probably a disc with a massive bone spur. This is not commonly present because see on this side, this is on the right side. It's not there. And next to it, you can maybe make out.
This is the rear.
So if I touch your in the back, you feel the bone sticking out in the back.
Yeah.
That is this bone.
I can't remember the name of that.
Spinous process.
Okay.
Spinous process. These are joints on the side.
Right.
But here, see this little round thing?
That's the spinal.
That's the disc. There's no spinal cord down there.
Oh.
Just for a sake of clarity.
Oh. Okay.
Spinal cord ends way higher up.
It's just nerves.
It's only nerves.
Okay.
And that is important in terms of, from a technical aspect, understanding.
Okay.
So this presence of this thing here, really, it was going to be a challenging surgery anyway. But presence of this here, because normally I can shave down this joint, get down here and get to this, but I had this piece of bone here. Okay. So let's, I want to, you're a very knowledgeable person.
Okay.
I want to give you some technical details, but not overcomplicate the picture.
Of course.
So we have this thing. So let's go over this. What is our goal? Our goal is to unpinch the nerves.
Right.
So you would feel better.
Yeah.
That's what was done the 3 first times.
Sure.
There are a few ways of unpinching it. How you unpinch it depends on what's causing the impingement.
Yeah.
Many times it's like a disc herniation. I suspect your first ones were herniated disc or something that was removed. Very classic surgery, very gratifying. You make a small opening, remove this piece of lobster meat.
Right.
Very nice. Other times, as we get older, impingement is called by overgrown joint and overgrown ligament. Similar concept, different surgery, but in both of them, we don't do a fusion. We don't need to. We just shave things down because we don't need to put screws and rods.
Right.
Okay. So other ways we may unpinch the nerve, we need to put screws and rods. And why we need to do that? A couple of different reasons. One is people have bad slips, they're unstable.
Oh, you mean
slipping
right.
means.
Okay.
Or the disc is totally collapsed, and what does the fusion allow us to do? That's the first thing. What it allows us to.
I have a question. When the disc gets closer to, the vertebrae
Yes.
closer together, does it reduce the hole? And the hole on the side is foraminal?
For foramina. I'll show you a picture. I'll answer that question. That's a very good question, and I'll show you a picture. I'll answer that. Because in the report, it mentions there severe foraminal stenosis.
Yeah.
That is not correct. On one side, there's moderate. We can say that much better on MRI.
Okay.
On the CT, you can make a guess, but you actually can't see the nerve.
I see.
I'll definitely come to that because that has implication in decision making. For example, since you asked that, we can talk. If you came in and you said, I got severe pain going the front of my thigh, we would definitely have to do a fusion because that would be coming from foraminal stenosis.
I see.
And the only way to address it is put a spacer in, open that space up, remove the joint completely. It would be a different solution because that's where, and that's when I do a lot of the fusions. And so, yes, so that when the disc collapses, sometimes there is severe foraminal stenosis of some degree. Many times there isn't. And I'll show you your pictures.
Okay.
Right. So going back, the goal is to unpinch the nerves. How we do them is what we talked about. Your case is very unique. You've had 3 previous surgeries, all from the right.
Right.
On the left side, even though there hasn't been a surgery, it has developed that crazy complex of totally piece of rock sticking out next to the disc, which is partially calcified.
Bone growth?
It's bone growth. It's like a massive bone spur.
Well,
And bones do that. It's just wear and tear over there, bone spurs. That crack I was thinking in your spine, that was actually a bone spur.
oh.
So it was definitely floating bones, so bone spurs formed. So that definitely complicates the decision making.
Yeah.
Because, okay, I'll come to it because since we're talking about the foraminal stenosis, this is what I was talking about. So this is the big disc sticking out, right? 4, 5, bone on bone. See that round structures coming out there? Round structures there? These round structures surrounded by white?
Yeah, right.
That's nerve coming out surrounded by fat. This is totally normal level. It looks totally normal.
Okay.
So we can see at level, even at that level, you can see your disc is contacting that nerve. See the black thing?
Yeah.
It's contacting it, but not flattening it. So that's by definition not severe foraminal. So even though you're bone on bone, your foraminal stenosis is not thankfully significant. On the other side, though, it's a little bit more maybe. You can see.
Are we going down like?
We're going side to side.
Okay, gotcha.
Yeah?
That's neat.
So on the right side, your foraminal stenosis is a little bit more. You can see that disc is pushing up more. Now, reason it's not causing you symptoms, your 4-5 is pretty much acting like it's fused. There's no motion there because the disc is totally gone.
It's just sitting on top.
So that's actually protecting you from the foraminal stenosis because if you were pushing and disc was pushing out, it would pinch that nerve more, but that is not happening.
So when they do a laminectomy, are they making the foraminal hole bigger?
No, that's not some part of it. You can't really. You can make it a little bit bigger, but not completely, because to get that bigger, that's where you have to often do what's called a complete facetectomy, remove the joints completely, put spacer in, and that gives the foramen.
Oh, and raise it. Okay. You mean like artificial discs?
No, spacers. The artificial is totally different surgery, so we won't go there. Okay. All right. So in your case, because of this situation, let's talk about 2 options. One would be just a decompression. We can use whatever verbiage because it's not a straight microdiscectomy. It's a partial facetectomy, laminectomy, discectomy. We can call it whatever.
Okay.
That's all just semantics at times. What's the advantage of that? Number one, we can consider it because you're not unstable. You're not moving back and forth. You're actually sitting pretty stable. Okay. The advantage of that is I can just go on one side, shave down that joint, and in hope of removing that pressure. The reason I say hope, when normally there's a disc and a nerve, I can go in there, I can just peel back the nerve a little bit to look at the disc. In this situation, oftentimes it's stuck like Scotch tape. And you're talking about trying to remove Scotch tape from tissue paper. It is very difficult, and definitely anyone who's had previous surgery at that level, whether it's right or left, there's scarring. Or anyway. Now you have second form of scarring with the bone spur, and your disc is also partially calcified. It's also becoming bone. All right?
Really?
So yours, in that case, is there still chance of success? Yes. I would say when I normally do these surgeries, laminotomies, microdiscectomies, it's 90-95%. It's one of my most successful surgeries. However, in this thing, I can't remove the joint completely because I'll make you unstable. You're stable now. I can move up to 1/3 of it, but to get a lot of room and work safely to give the best chance, I need to remove all of it. I can't do that without a fusion. So if I can do smaller surgery, certainly an option. I would say chance of success is probably like 70%. The reason I say that is I may get in there and things are so stuck down, I can't work safely around the nerves.
Yeah.
Working about tearing it up. The risk of spinal fluid leak in general in my hand is 1%. In this case, it's probably good 5%.
Mm-hmm.
Okay.
Normally 1%.
Normally 1%.
Okay.
Now, the surgery takes about yours will be, if you do it a little bit longer, probably hour, right? And sometimes, micro disc is 30 minutes to 45 minutes. This is hour and a half.
Right. Yeah.
Okay. What's the other option? Other option is to say, listen, you already lost motion at that level. Because fuse it. Because why don't we do fusion? I try and avoid them. Preserve motion.
Right.
You already lost the motion. It's not like you're losing anymore. And what's the advantage of it? I can remove both joints. Actually, surprisingly, on the right side, you may not be as scarred because you haven't formed as much bone.
That's weird.
Right? I have maneuvers I can do by removing the joints. I can work in a safer channel. I can remove more pressure. It gives more of a 90% chance of successful decompression.
And we're talking fusion.
Fusion.
Right.
What's the downside of fusion? Longer surgery, longer recovery.
Yeah,
about I would say your surgery will take between 2 and 3 hours. Normal disadvantage, which is loss of motion, doesn't apply to you because you don't have any motion there. There is going to be
so since I don't have motion there, does it put more pressure on
above and below? Yes.
It does.
So that's one of the reasons we avoid fusions when we can, is to prevent adjacent level disease.
Yeah, right.
But in your case, that's already been happening, and your adjacent levels are thankfully doing great.
Okay.
So your weighting down of the natural levels will be no more than what's called natural history. If you don't do it.
L2, L3, I noticed they talked about.
What is this?
Right? L2, L3. Is that because my bones have naturally fused?
No. Yeah, L2, L3 looks fine. I don't know what he mentioned.
Really?
I would honestly, a lot of the stuff they would mention sometimes.
Yeah,
your L2, L3 on MRI is totally normal.
And he also mentioned central canal stenosis.
Which is on the CT, which is more lateral recess. Again, the judge stenosis on CT is not the best.
Yeah.
MRI is good.
No, it was MRI when he said central canal stenosis.
By the way, L2, 3, very mild degenerative changes. I don't know why he called them moderate stenosis.
So there's probably no pain coming from
I would not even, I would ignore it. That's just a judgment call.
Okay.
I would not worry about that at all. Yeah. So you do have severe stenosis, but canal, when I take it, it's both sides like this. Yours is like you see in the picture, on one side you can see the nerves.
Yeah.
So how can it be canal stenosis when you can see the individual nerves? You have very severe left-sided canal stenosis.
And usually it doesn't, when you do 3 operations on the right, I would have bone spurs and things.
Not necessarily. There's more scarring than bone spurs. Your bone spurs formation on the other side is very atypical.
It is.
Degree, and I do thousands of these. I've done 10,000 cases here.
Wow.
I see that probably 1 out of 500. To see this degree of bone formation, there's always some calcification. I've seen ligament calcified.
Yeah.
But to see this bone spur just sticking right out of the bone, plus that is unusual to that degree. It asks the challenge of what we're trying to achieve. So that's why I want to discuss with you that we have these 2 options.
Right.
And I want to get your sense. I am amenable to doing both.
Right.
As long as
if it was you would do a fusion if it was on your back.
I gotta tell you, I gotta be in that situation to know. It would not be wrong to say, let's do a smaller surgery and see if we can get away with it. It would not be wrong to say that, okay? Because quicker recovery, etc. But then, and everyone's different. Some people are like, hey,
You go in and try the smaller surgery, and if you can remove the nerve and not stuck to the, what did you say the nerve might be stuck to?
The dura, the coverings of that.
And then switch, and then
we can make it a bigger surgery if possible. Is that what you're saying?
Yeah.
Needed? That's a good call. I just have to apologize. It's possible. We just have to plan everything in advance in terms of, and it gets tricky with insurance standpoint sometimes. It is possible that we can do that. As long as you're okay with me converting into a fusion.
Of course.
Are you good with that?
Yeah,
okay.
Because Um,
I apologize.
like you said, I'd rather go the small one.
Yeah.
Because of less recovery time.
Okay.
But if you can't do it, then obviously I need the fusion.
So let's plan on that.
Okay.
What I will do, we have it for tomorrow. I'll have to move some things around.
Okay.
Because I got to talk to OR. Hopefully they give me enough time.
Okay.
Okay. What we'll do is if they say, hey, we got time, then I'll keep it tomorrow.
Okay.
We'll plan to do the smaller surgery in the hope that is enough, and we can get it done safely and effectively.
Right.
But if I feel, man, this is too hard, we're getting into problems, we'll set up everything like it's a fusion. Because you have
Right.
everything.
Yeah, right.
And then we'll convert it into a fusion.
Right. And then I wake up and then you tell me.
Yeah, you'll tell you.
Yeah.
Because that way, hope the chances having great relief are better instead of having to go in again.
I understand, yeah.
Okay. So actually, what I'll do is I'm going to head to the OR. They're calling me, but it's a great place to be because I'm going to ask them about tomorrow.
Okay.
So the risks are similar. It's just length of surgery and postoperative pain will be different.
Yeah.
The risk of spinal fluid leak is actually lower.
Right.
Because I have more room to work with because I can remove the joint.
If it's a fusion.
If it's a fusion.
Right.
But your postoperative pain in the fusion will be higher.
And
more muscle dissection.
Fusion, we meaning rods and and
you'll have 2 spacers.
Right.
And 4 screws, 2 rods.
Yeah.
Yeah. You have nice big bones, so we'll get nice big screws in there.
Okay.
And so I think that is a very good idea.
Yeah.
Normally, we don't have that option. Because if you're seeing patients outpatient, insurance will approve one or the other.
Oh,
it's very complicated.
Do I need to worry about that with Anthem?
Let me call my scheduler.
Okay.
Because I don't want them to create problems for you and for me.
Right.
And this is also a recent development, by the way. Up to a couple of years ago, I can do whatever I feel is appropriate.
Really?
And they will not have a problem. Now they said, if you admit a patient from the ER even, or direct admit an emergency, you have to get authorization. Like, seriously?
Right.
I'm not admitting this guy is upsetting my schedule for the fun of it.
How do I get authorization?
My scheduler will do that.
Okay.
Let me call her right now.
You know I have Anthem.
Yes.
You have all my info.
Yeah, she has it. Let me talk to her.
Okay.
Let me see what she says.
Okay.
If there is no problem with that, that is what we'll plan.
Okay.
I'm going to hit the OR. I'll make these calls, and we'll have a follow-up conversation.
I trust you very much.
All right?
I trust you.
All right. Thank you.
I do. And I know you'll be the best for me, and I like that plan.
Okay. No, me too. I like that. So let me talk to a couple of people and see
what
I can.
Yeah, and I'll be here.
Okay. You want this back?
Yeah, might as well. Actually, I've eaten everything.
You don't have the table here.
Yeah. And I should have been eating more calcium, huh? I mean, honestly, but my bone's okay. Okay. Thank you, Dr. Murado. Did you get that? Well, he set up, yeah. Right. Well, yeah, I can't see it from an MRI, but you know what? We would just have to fight the insurance company to say I was out of it. I didn't know, I like that idea. I like the idea that if you can do the smaller one, and there's no problem with the nerve getting stuck, then do the small one. And what's nice is we don't even have to worry about authorization. His scheduler handles it, and I know who that is. That's Glass. I know who that is. He does all that stuff. So I don't know how they're going to present it to him, but I trust him, and we'll just go with, if they don't and they only approve one or the other, then I'll let him decide. He doesn't want to, but I'll manipulate him into making the decision. Okay?